afternoon, namaste, everyone, respected chairs, and all the presenters and the audience present here. So my name is Ayuska, and today I'll be presenting on gendered experiences of female community health volunteers in Nepal, implications for policy and practice during post-COVID-19. During and post-COVID-19. So let us enter into the content. Female community health volunteer program was initiated was initiated since 1988, and at the present there are approximately 52,000 FCHVs in Nepal who are actively working in all the communities of 77 districts of Nepal. So FCHVs are considered as one of the key component who actually bridges the gap between the community people and the local health systems. Also, FCHV's engagement in the community are mostly focused on community-based preventive and promotive health care activities, which has already been proven as key element in progress of many health indicators, especially maternal and child health indicators. So therefore, FCHVs forms critical linkages for the prevention and control of COVID-19. Therefore, the national guideline calls FCHVs to be a part of COVID response team in coordination with local management. I was extremely sorry. Yeah, so I just completed background, so I'll be going on with the objective. The objective of this study is to explore the roles of FCHVs and their gendered experiences during the COVID-19, during and post-COVID-19 in Nepal. So moving to the methodology, this study was conducted following qualitative approach where in-depth interview and key informant interview were used as methods of data collection, which was conducted after receiving ethical approval from NHRC. So data was collected between December 2020 and January 2021. In total, 22 interviews were conducted, where 13 interviews were conducted with female health community volunteers, and 9 interviews were conducted with key informants who were closely working with FCHVs. So thematic framework analysis was conducted in this study, which was guided by Morgan's et al. And Steele's et al.'s framework. So this is the framework that was used in this study. So the first one, Morgan's framework, speaks about gender as power relation and driver of inequality, whereas the second one speaks about influence of gender norms in relationship between health system, community, and close to community service providers. So now let us move to the regional section. So let us first discuss on what were the roles of FCHVs during the COVID-19. So COVID-specific roles of the FCHVs were creating awareness at the community level, distribution of hygiene kits, which contained sanitizer, mask, chlorine powder, and other hygiene-related products in it. Tracking, screening, registering, following up, and referral of the people with COVID-19 who were staying in home quarantines. So FCHVs also supported health workers who were working in the sector of COVID-19, especially in the field of contract tracing and case follow-up. But a point to remember here is not all FCHVs initiated the activities at the same time frame. It actually varied according to different wards and municipalities. And also some of the FCHVs were working some of the FCHVs were engaged in COVID-specific groups which were formed at the local level to prevent and control COVID-19. Now let us look at the motivations. What actually motivated FCHVs? So first one was willingness to do social service. So FCHVs were really interested to do social service where they can improve the lives of vulnerable population and reach the people who were yet unreached. So another most important factor was trust gained from community. Trust and respect gained from community was another important factor that motivated FCHV to contribute during the COVID-19. And also FCHV served the community specifically during the COVID-19 because they perceived it as their moral responsibility. At the end, various opportunities that FCSB received while working as a community health worker. Like they had opportunity to receive and share their knowledge with the community members, which made them which made them feeling of self-empowerment, and it has contributed to their knowledge enhancement. So now let us, FCSVs conducted various COVID-specific and also their general roles during the pandemic. But some of the FCSVs had perceived that their workload was increased because community people frequently contacted FCSVs, especially during the time of lockdown when routine healthcare services were disrupted. So, and on the other hand, gendered division of labor, which actually expects female to carry out household activities and take care of family members as a primary responsibility. All of these factors increased the workload of the FCSVs, which was particularly more challenging when the work came unplanned. So similarly, another experiences of FCSV was like they were stigmatized and discriminated while working during the COVID-19 pandemic, because community people feared that FCSVs could transfer the infection. This was the reason behind this was FCSV closely worked with health workers from the health post. They had frequent contact with COVID-19 patients who were staying in the home quarantine, and they were also carrying out their roles in the quarantine centers. So yeah, because of increased exposure, they feared that FCSVs was a main source of COVID infection. So in such instances, locally elected representatives, ward chairpersons, such as ward chairpersons, health coordinators, and health post in charge, they supported FCSVs and helped in convincing community people for their cooperation. Similarly, planning, implementation, decision process were not always gender inclusive and gender sensitive. This was evidenced by the information we obtained from KII and IDI, where FCSVs were unaware about their membership in the COVID-specific groups which were formed at the local level. And also they were unaware about the formulation of groups at their own areas. So FCSVs perceived the reason behind this was that men attributed most of the higher positions and decision-making roles in our society. So the last one is the lack of adequate support, particularly from men. When FCSVs conducted household visit and community visit, especially to create awareness about the COVID-19, FCSVs perceived that there was lack of support, particularly from men community members. The perceived reason behind this was patriarchal gender norms, which is practiced in our society, which suggest men is superior than the women. So this led to male community members being less receptive to the information provided by the female community health volunteers. So despite of these various challenges, FCSVs found challenging to balance their workload and balance their work life and family life. In such instances, family support were very crucial to them. Some of the FCSVs received family support where they were assisted in completing household chores such as cooking food, taking care of children, and in some cases FCSVs were also accompanied and arranged for transportation during the lockdown period by the family members. But unfortunately, not all FCSVs received support from their family members. This was because voluntary nature of work without any form of benefits, concern around safety of FCSVs themselves and their family members, and also inability to timely accomplish their household responsibilities, such as they could not cook and feed the family members and children timely. And the last one, since the FCSVs have been working for a long period of time, they have adopted coping mechanism by their own, where they woke up early in the morning to complete the household chores before they left for the duty as community health volunteer. However, FCHV perceived an additional role of COVID-19 as an opportunity to be empowered by gaining and sharing the knowledge. Now let us look at let us look at from the health system's perspective. There were limited and special formal trainings and orientations about COVID-19, and there were also inadequate and uneven supply of safety measures such as masks, gloves, and sanitizers. And especially during the initial days of COVID-19, when there were lack of clarity about the disease in itself, FCHV were mobilized in such cases, and they shared us about their experience of feeling stressed and anxious. In such cases, there were lack of formal mental health support program for FCHVs. And also limited financial support for the additional roles despite the policy. So the policy here means the document or guidelines that actually guides COVID-specific groups formed at the local level, namely COVID prevention group and COVID facilitation group, where it has mentioned that on the day of being mobilized, any kind of volunteers will receive certain amount of remunerations. But in the field, it was actually lacking. So all of these factors resulted in restrictions from family members to work during the pandemic due to insufficient safety measures, which ultimately demotivated female community health volunteers to do their work. Now, what did they do to cope with these situations? So, especially when there was lack of trainings, FCHVs had to rely on information from other sources such as radio, television, and caller tune in their mobile phones. Similarly, when there was uneven and inadequate supply of basic protection items, they reused their masks and bought the safety measures on their own. And FCHVs, even though they did not receive formal mental health support, but they received informal support from supervisors and health workers. And also, FCHV worked on COVID-19 related activities as a part of their regular responsibilities. Hence, they did not expect any kind of remuneration from the health system. So, with this, I would like to conclude here. Our study acted as an initial point, or let's say starting point, to explore gendered experiences faced by female community health volunteers, which actually revealed how access to resources, defined gender norms and values, defined division of labor, influenced or shaped the experiences of FCHVs. Therefore, attention must be paid to the female community health volunteers' multiple responsibilities needed to be carried out as a woman and close to community service provider. This would not only ensure effective roles of FCHVs, but also result in improved health outcomes of the community. Therefore, addressing gender challenges and inequities of CTC providers would contribute health system to be more responsive during various fragile and shock-prone situations like COVID-19. Thank you.